Hello everyone and welcome to this SHAPE webinar with myself, Monica Slavin, and Dr. Tuan Mercier today. This is the last in a series of SHAPE antifungal webinars, and as you can see here, there's been a really fantastic selection of speakers and topics already covered, and today's is, as I say, the last. So today's agenda, first of all, you will be hearing from Tuan, and he'll be talking about approaches to the management of invasive mold disease, and then you will hear from me with a case study. So I'd now like to introduce Dr. Tuan Mercier, who's from the Faculty of Medicine, University Hospital, Leuven, Belgium, and he will talk to us now about maximising treatment and new approaches. Tuan, over to you.
All right, thank you very much, Monica. So first of all, let me start with my disclosures, and then let's move on to the main part of the lecture, where I'll be going over the different possible management strategies for antifungal treatment. And I'll start with a brief overview of all possible management strategies for basically any infectious disease, not just fungal diseases, but any disease. And I'll also give an example outside of fungal infections for each strategy. So the first strategy, of course, is prophylaxis. Prophylaxis is where you treat all patients that are at high or very high risk. For example, when you give cotrimoxazole in AIDS patients to prevent pneumocystis infection. It's of course very easy. You select the patient population that you want to treat or that you want to protect. You treat all of them in the same way, and you don't need to worry about anything anymore. On the downside, of course, there is a lot of cost involved because you are treating a lot of patients who potentially don't need treatment. There are drug-drug interactions, there's potential toxicity, and you might induce resistance. Specifically for antifungal prophylaxis, there's also the other downside that prophylaxis decreases the sensitivity of most, if not all, fungal diagnostic tests. So if you treat a patient with prophylaxis, it makes it a bit harder to detect breakthrough infections. Then moving on to the next strategy, which is empiric therapy, where you don't treat all patients up front, but you start treatment as soon as you have a clinical picture which is compatible with the disease you are looking for. For example, if you have a patient with pharyngitis, you start beta-lactam treatment. Some cases, for example, in outpatient clinics or in the GP's office without any microbial testing being performed. Of course, this reduces the patients that are being exposed to drugs, but you will still overtreat some patients who do not have a bacterial infection, for example, or a fungal infection, but they just have a clinical picture which resembles the infection you are treating. Getting more narrow and smaller, preemptive therapy is where you screen a group and you start treatment based on the screening results. For example, something we all going through right now is COVID PCR testing, where you test a whole population, for example, border crossings, and you act based on the results of the microbial testing. It's of course very lab intensive. Costs depend on the cost of diagnostics versus the cost of treatment, but you do expose a smaller group of patients to potential side effects. And finally, the most narrow approach is the diagnostics-driven therapy, where you have a patient with compatible clinical signs and symptoms, and where you start treatment based on microbial tests. For example, you do a PCR test for influenza and start as soon as a rapid test comes back positive. You have the smallest group possible that is being exposed to drugs and possible side effects. But of course, you need a lot of specialized testing. You need to get your results fast, and you need to have accurate diagnostics. Testing can also be potentially invasive. When we think about fungal infections, we think about things like bronchoscopy, biopsies, things like that, which are, of course, not the most comfortable things to go through. Now, let's apply these things to our population of patients at risk and see how we can apply these principles. Now, why do we worry this much about fungal infections, and why do we really want to treat them? Well, you want to catch a fungal infection fast. I have shown the three main infections here, candidemia, aspergillosis, and a much more rare but still very relevant mucormycosis. And you see that it doesn't really matter which type of infection we are talking about. If you delay, if you miss the infection, the patient will have a severely increased risk of dying. So you need to find a fungal infection fast. All right. I don't have sufficient time to go over all the approaches in deep detail, so I will be providing you with all the building blocks for each approach, and that should be allowing you to tailor the approach to your own personal local situation based on all the drugs that are available to you, all the diagnostics you have, and how fast you can get them. And in order to build such a tailored approach, you need to know three main building blocks. First of all, there's the epidemiology of your local patients and infections. There's, of course, the therapeutic options and the diagnostic options. And let's go into a bit more detail into each one of them. If we look at epidemiology, of course, there's the who. Who are my patients and what are their risks? For example, I'm working in hematology, so most of the diseases on this slide will be hematological diseases. And if we look at the low risk end of the spectrum, we have patients with, for example, a lymphoma, with myeloma. Their risk is not zero. There is a certain risk of a couple percentage points, but it's not typically what we would expect a patient to have when we think about fungal diseases. If we look at high-risk patients, we think about patients with acute myeloid leukemia, patients undergoing allogeneic stem cell transplantations, things like that. These patients have a very high risk. And it's not just who the patient is, it's also when the patient is presenting himself. For example, I've shown here the graph for a transplant patient undergoing allogeneic transplantation. And if you look at the first part, before the transplant has engrafted, before white blood cell recovery has taken place, see that there's a high risk of candidemia. And after engraftment, there's a high risk of pneumocystis. Aspergillus occurs all throughout this disease course, starting from 7 to 10 days of deep neutropenia. And of course, I already mentioned it in passing a few slides back, but low risk does not mean no risk. And so when we talk about patient populations, we can talk about them in percentages, we can talk about low or high risk, but we can also talk about them in absolute numbers. And to know these, you need to take into account the patient population size as well. And that's something which is not often mentioned. For example, we always talk about acute leukemia for invasive aspergillosis, and they do have a high risk, between 5 to 20% based on local epidemiology. But worldwide, there's only about 100,000 cases every year of acute leukemia, which means we only have a few thousand patients with invasive aspergillosis in acute myeloid leukemia. If we look at things like COPD, which typically is thought of as having a low risk, few percentage points of having invasive aspergillosis. However, there are many, many times more patients with COPD every year, over 12 million in Europe and Asia alone. And if you multiply those two numbers, you get to a population size which is several times larger than the typical leukemia population. So it's something to keep in mind. It's not because there's a low risk that you won't see a lot of patients with invasive aspergillosis with these diseases. Moving on, there are also other new emerging risk factors that we don't typically think of or weren't thinking of when talking about invasive mold disease. So I'll go over a few of those. First of all, there's Bruton kinase inhibition, things like ibrutinib, acalabrutinib. And there have been several series now reporting invasive aspergillosis in these cases, even if they were not treated with other drugs. However, a thing that was often missing was the population size, the population at risk. So we only had absolute numbers, but no relative numbers. A while ago, luckily, there was a large series, and they reported a rather low risk of about 2%. So there is some risk there, but it's not a huge risk, luckily. But you do need to keep it in the back of the mind, even in a patient who is being treated with a BTK inhibitor in monotherapy. CAR T cells are being used for a couple of years now. They get induction treatment with some form of chemotherapy, fludarabine and cyclophosphamide, things like that. And so the risk is similar to the risk seen with similar types of chemotherapy. There's no specifically increased risk in these patients. If we then go to checkpoint inhibitors, there's not an increased risk. This is something that is a fallacy in a lot of places, but checkpoint inhibitors do not increase risk. On the other hand, they might even be beneficial when looking at it from a theoretical standpoint. It's not been proven clinically, but it has been used in some small specific cases. Of course, there's not just treatment, there's also other host factors, things like patients with influenza, and then I'm talking, of course, about severe influenza requiring treatment at the ICU. And there's a nice paper that has been published a few years ago by Alexander Schouwvliegen, and it clearly shows influenza being a severe risk predictor for getting invasive aspergillosis. And it happens early on in the course of the disease progression. Of course, the thing that we then need to take in mind is how do we find influenza in these patients, because they never fit into the classical risk factors or the classification system, For example, the ERTC criteria were designed with oncological patients in mind, transplant patients in mind, but not with patients with influenza. So classification criteria were lacking, diagnostic aids was lacking. So a year ago, an expert opinion group came together and they designed these criteria, which you can use to either include patients in studies or to help you guide in the clinic, but they're mainly used for research purposes. Of course, in these days, it's impossible not to mention COVID-19. And as with other respiratory viral infections, we see that COVID-19 is also a risk factor for invasive aspergillosis, and it has been termed CAPA, COVID-associated pulmonary aspergillosis. And a few months ago, these guidelines were published as well, meant to be used both in research and in clinical routine. The classification criteria are a lot less strict, in my opinion, than all the other criteria that have been published so far. So they include a larger group of patients. The possible category relies on microbiological testing from non-bronchoscopy samples alone, for example, which is a lot less stringent than previous criteria. But keep that in mind, COVID patients do have an increased risk of invasive aspergillosis. So let's move on to the different strategies then, and I'll show some examples for invasive mold disease with some guidelines as well. So first of all, we had prophylaxis, where we treat all patients who have a high risk. And if we look at the European guidelines, the ESSO guidelines, you see that there are three possibilities with an A or B1 grading, with posaconazole clearly on top, having an A1 grading. As an alternative, you can use fluconazole or itraconazole if the risk of invasive mold disease is low in your local setting. However, keep in mind that if you do use posaconazole, you will lose some sensitivity with your diagnostic testing. If we look across the Atlantic, if we look at the American guidelines, basically they're the same. Posaconazole is first line, but you can use other azoles as an alternative. So this is an approach that is being used worldwide, Europe, Asia, America, all over the world. Now, all of these guidelines were created for mostly for oncology patients, leukemia patients, but as I mentioned before, influenza is also a risk factor, so it makes sense to try prophylaxis in this patient group. And this is a recently published paper from a few weeks ago, where they tried to provide prophylaxis with posaconazole in patients admitted to the ICU with influenza. And they did see a difference, but it was not statistically significant. And after some analysis, they found out that the rate of early influenza was higher than expected, which means that patients already had invasive aspergillosis the moment they were admitted at the intensive care. And of course, at that point in time, it's useless to start posaconazole prophylaxis because the patient already has the disease. So it might be that that's the reason why they could not find a significant difference, although there is a trend in increased mortality without prophylaxis. Now, moving on to empirical therapy, where we start treatment based on clinical presentation in the patient. And if we look at guidelines there, and these are the American guidelines, they state that if you have a patient who is febrile, who has a fever that doesn't go away despite broad antimicrobial treatment, bacterial treatment, for example, with a carbapenem, you should start some antifungal treatments with, for example, liposomal amphotericin B, and echinocandin or voriconazole. This is, of course, not very targeted treatment. You try to cover as much pathogens as possible in one go without really knowing what exactly is going on. Is this a good approach? Well, the EORTC has created a study to find out if treating without diagnostic testing or waiting for diagnostic testing is similar in outcomes, and results are expected any day now. So we should soon find out more about this. If we then look at directed therapies, where the patient is treated based on diagnostic findings, where you are reasonably certain to very certain that the patient has a specific fungal infection, we have different therapeutic options. And these are the European guidelines, and the two main drugs that are available to us and that have clear scientific evidence to them are voriconazole and isovuconazole, with isovuconazole being as effective as voriconazole, yet better tolerated, less interactions, things like that. So both of these get an A1 grading and are our main workhorse for invasive aspergillosis. If we look across the pond, it's basically the same story. So voriconazole and isovuconazole are both good options. So these two are being used worldwide as a first-line treatment in invasive aspergillosis. So to summarize, always keep in the back of your mind that even low-risk patients, which we don't typically think of as being at high risk of having invasive mold disease, are still at risk for invasive mold disease, especially if the patient group is large. You will see several patients even when they have a relatively low risk. So keep it in mind, especially since these diseases are still lethal if they are not treated in a timely way. How you do this, how you go about your approach, do you prefer prophylaxis, do you use a directed therapy, or do you use an empirical therapy, is very much based on the local epidemiology, on your available diagnostics and therapeutics, and the turnaround time of all of these. And with that, I hand over back to Professor Flavin.
Thank you so much, Tuan. So now I'm going to talk about a case, and this is a case of a patient with a brain lesion in a non-neutropenic patient. These are my disclosures. So this is a patient who'd had a childhood medulloblastoma and was undergoing yearly CT scan follow-up. So in 2000, the patient had had a medulloblastoma treated with surgical debulking and chemotherapy. There were several complications that ensued. In 2004, the patient developed chronic myeloid leukemia requiring treatment with imatinib. Also developed panhypopituitarism and steroid-induced insulin-dependent diabetes, and so was receiving prednisolone, thyroxine, and testosterone. This patient was working and was employed, lived on a rural property, and worked in some agricultural and sheet metal occupations, as well as living on the property. So the presentation was really one of follow-up CT scan detecting an abnormality, and this was a new left brain lesion, so 20 years after the initial medulloblastoma. And on questioning, the patient did have neurological deficits, and it was presumed at this time that this was radiation-induced high-grade glioma, and a decision was made by the oncologist to proceed directly to treatment. The patient was received temozolomide with radiation therapy. And at that time, the patient was also receiving some dexamethasone, so did get Bactrim prophylaxis and started on the course of radiation therapy and temozolomide. This is the lesion that was detected on the routine brain MRI. You can see the year before there was no lesion, and on the 2020 follow-up scan there was this lesion in the midbrain area. So this was treated, but followed up with a CT scan. And before finishing the temozolomide and whole brain radiotherapy, it was noted that the patient had developed a new right temporal lesion, and this was associated with some behavioural changes and confusion. So the radiation and the temozolomide was ceased to work up this new brain lesion that had appeared during treatment for the presumed high-grade glioma. As you can see here, these are the new lesions. There was this new lesion here and also a cerebellar lesion that was detected whilst the patient was being treated for the glioblastoma. So this resulted in a series of investigations, including serologies and a lumbar puncture. The serologies were rather unremarkable, and the lumbar puncture really just showed an elevated protein and glucose, but bearing in mind that the patient had a high serum glucose at that time point, so it was not particularly abnormal. Because the serology was unhelpful, it was decided to proceed to the excision of this temporal lesion. So this lesion was excised, and what was visualised on calcifluor staining of the brain biopsy were fungal hyphae. And so immediately voriconazole therapy was started and imatinib was ceased due to the potential drug-drug interactions with voriconazole. There was some reassurance in doing this as the BCR-ABL gene was completely suppressed at that time. So it was thought safe to stop imatinib. The culture then identified Aspergillus flavus in this patient, and you could see these branching structures seen on the GMS stain of the brain biopsy, and as well as the culture showing Aspergillus. So this organism luckily was highly susceptible. It was susceptible to all the azoles and also to amphotericin B, but really on the borderline of susceptibility to amphotericin B. So in considering the treatment, the decision was made to go with voriconazole, and that was partly based on clinical experience. We know there are clinical case series supporting the use of voriconazole in Aspergillus brain lesions, but also on the data that we know from brain and CSF plasma to drug ratios being quite favourable for voriconazole as compared potentially to posaconazole or itraconazole, isavuconazole, where we don't have as much evidence, but where animal models do support a brain ratio of greater than 1 in brain tissue, although low CSF levels. So our initial choice in this case was voriconazole. So what happened with the patient? The patient started on voriconazole, but unfortunately persistently had rather high voriconazole levels, along with some disturbance in their liver function tests, which got worse despite adjustment of the voriconazole dose. And so a decision was made to switch the patient to isavuconazole because of the really lack of improvement of liver function tests over time and concern about the dosing that we were able to give with voriconazole. So the other issue that the patient had had with voriconazole was hyperpigmentation and skin changes, which gradually improved after starting isavuconazole, as did the liver function tests. So really the patient remained on isavuconazole over the next subsequent months. We also looked to see if we could find a source for this Aspergillus in the brain, and there were some abnormalities seen on the patient's chest CT scan, which could have represented previous Aspergillus infection, although we didn't pursue this further. How did the patient respond? Well, over time, there was an improvement in these lesions here. You can see on the subsequent scan in June that this lesion has improved. And again, the MRI showed perhaps not so much change in the cerebellar lesion as there was in the temporal lobe lesion. So I'd like to talk a little bit about Aspergillus flavus brain abscess in this patient, which was rather unexpected finding. I'll talk a little bit about risk diagnostics and antifungal choice. So we know that this patient was exposed to potentially Aspergillus in their environment. He worked sorting nuts in a factory and also had lived on a rural property with agricultural exposure. And I think this is a very nice summary of some of the environmental factors that have been associated with increased risk for aspergillosis over time. But interestingly, this was not a patient that we traditionally think to be at high risk for invasive aspergillus infection. What do we know about temozolomide, as that's frequently used to treat brain tumours? And there is certainly a case series reporting infections. What we know is that pneumocystis is more common in patients on temozolomide, particularly in combination with steroids. But there are several case reports of fungal infections within the brain, including a case of Aspergillus terreus previously, as well as cryptococcosis. And there's been some recent work done looking at how temozolomide does kill tumour cells. And I think this is quite interesting because it's described as being by the process of ferroptosis, which may then release iron into the tissues. And we know that fungal organisms do require iron for their growth, etc. So it is a theory that might be further explored, although we know from the literature, and this was a fairly extensive literature review over a number of years, there were not a high number of cases of mould infections seen in the literature. There has been a previous case report of temozolomide and cerebral aspergillosis, very similar case to ours, where this was being used for glioblastoma multiforme, along with dexamethasone and radiation therapy. And this patient developed a brain lesion and a lung nodule. And interestingly, the galactomannan in serum and the beta-glucan were negative in this case. Was not reported whether CSF was examined with these tests. So how do these non-culture-based tests work in CNS lesions? And I think, first of all, we really do rely on the standard diagnostics of microscopy on a fresh specimen, fluorescent staining such as calcifluor to show the fungal elements, and of course image-guided stereotactic brain biopsies. Histopathology with the traditional stains as well as calcifluor, and of course now we have the option to use DNA sequencing as well to try and identify fungal lesions, although this is probably most high yield where you can see fungal hyphae, but you don't grow them. Turning to the non-culture-based tests, there's been several publications examining their performance, largely in meningitis rather than brain lesions, but many of these series had both patients with meningitis and brain lesions. And you can see from the literature, the series are not large. The number of patients is shown here in this column, and this is the total number of patients examined, positives and negatives in these series. But from these small series, it does appear that galactomannan has a reasonable sensitivity and specificity, as does Aspergillus PCR. And also there is one meta-analysis looking at beta-glucan showing that its performance was reasonable. But we must remember that this will not tell us what the fungal lesion is, unlike the galactomannan and PCR, which are more targeted towards Aspergillus. The one beta-glucan could occur in a number of different fungal organisms. So what about using a savuconazole as we did in this patient? We know from the SECURE study that it performed similar to voriconazole in treating invasive aspergillosis. But again, many of the cases in this series were pulmonary cases rather than cerebral lesions. But what we did learn from this series, apart from it being equivalent to voriconazole in the treatment of pulmonary aspergillosis, was that there were fewer skin, eye and visual and hepatic dysfunction issues seen in patients receiving isavuconazole than voriconazole. Thus our decision to try it in this patient who was having abnormal liver function tests and also changes in their skin, which they were quite concerned about. And of course, the also benefit of isavuconazole is the fewer drug-drug interactions, seeing that it only interacts with CYP3A4 and none of the other cytochrome P450 enzymes. So what do we know about it in treating CNS lesions? There has been an analysis of isavuconazole, open label, in patients with CNS, invasive fungal disease, and this was a small series of 36 patients, but there were a number of aspergillus brain lesions, 8 included in this series, 3 of which were aspergillus flavus. And the overall response rates are shown here. Probably about over half the patients had either a complete, partial or stable response whilst on isavuconazole, which is, I think, a reasonable response rate, but difficult to say in that we don't have a comparator arm in this study. But again, gave us some reassurance in using the drug in this patient. Just briefly to talk about the drug-drug interactions, we know that imatinib is metabolized by CYP3A4 and 3A5, and that isavuconazole is a weaker inhibitor than voriconazole, posaconazole and itraconazole. But again, we did recommence imatinib in this patient and carefully watch for interactions was the approach that we took. So I guess in summary, to talk about this case, this was a case where we didn't have a high suspicion and in fact were quite surprised to find that this patient had invasive aspergillosis. Going back through the literature, we can see that there have been cases of invasive brain aspergillosis in patients receiving similar therapy with temozolomide for brain cancers. And so it is something that does occur, although albeit rather rarely. In this patient, voriconazole, there were issues with liver function and skin. So we switched to isavuconazole, and there was a partial improvement, as you saw on the cerebral lesions. One of them had almost disappeared and one of them was stable, but overall not a bad response over 4 months of treatment. And I think, again, this really shows that we should think about fungal infections, even in those situations where we're not really expecting them. And I think that aligns with what Tuan was saying in his presentation about always think about fungus as a differential diagnosis and always try and get a biopsy and try and look to it for the best of your abilities in these unusual cases. So I really want to thank you, Tuan, for taking on all those wide and varied topics in the discussion. But it was a really useful discussion, I think, and very interesting and valuable to hear your experience with the lateral flow and other diagnostics. And again, thank you for a really wonderful review of antifungal therapy and how and when we should use it. So I think I would like to just remind everyone to complete the evaluation and to thank you all for your attention, to thank Tuan for his excellent presentation, and thank you to Pfizer for supporting this educational activity. And we shall finish there. Thank you and goodbye.